or understanding why advancement of the mandible causes the problems that it does, and exactly what to do about it. And I mean, in most cases, that word exactly is appropriate. And that may sound like a lot to promise, but I think we can back it up. I do not have any conflicts of interest to disclose. One of the objectives to understand why advancement of the mandible causes the formation of what's called myofascial trigger points, the source of most of the adverse effects from the treatment of sleep apnea with all devices. Number two, provide you with a basic understanding of what causes myofascial trigger points to form. Thirdly, to demonstrate limitations of most of what we refer to as morning occlusal guides to correct the bite and reverse symptoms, and why they are often ineffective. Lastly, to learn alternative exercises in place of MOGs to better control adverse effects from MAD/OAT therapy. And I might use those terms a little bit interchangeably, be confused. All right. So, in your practice, I'm certain that this is an oft-heard complaint. My bites off, I have symptoms. Tell your patient. What do you tell your patient when you hear this? So we might tell our patients having problems, look, why don't you just use it every other night, or at least turn it back. And heck, if we can't get them comfortable, they'll just go back to using CPAP, right? Well, in most cases, I would say that's maybe a bit naive, and they're not going to go back using CPAP. It's going to take active Congress to convince them they might need to consider it. We are the last stop, oftentimes, before they give this whole thing up. And patients just don't understand. This is not just about sleeping well or not snoring, which is what prompted them to come to you initially. It's about the very, very adverse health effects that this will have if they do not address their sleep apnea. And so we have to take this very seriously. So in the past, I might have told the patient, okay, let's dial that mouthpiece back a little bit, and it feels better and they're happy, pain subsides. But then their apneic events, they're snoring, they're feeling tired, they're waking up to go to the bathroom at nighttime, and the consequences can be far more serious than just jaw pain. That is for certain. I know I'm being redundant, but it's very important, very serious, and because sleep apnea is a risk factor more than any other single medical condition for very adverse medical consequences, including smoking, obesity, etc. Nearly 80% of nocturnal strokes are directly attributable to obstructive sleep apnea. And here is a list of numerous conditions that are associated with untreated or inadequately managed obstructive sleep apnea. This is what I'm always reminding my patients of, that this is just not about not snoring, which is what brings most people in. It's about not having or worsening of conditions like hypertension, AFib, diabetes, etc. And a lot of patients really don't understand that. They do once you explain it to them, but hypertension is just not because you have a deficiency in a beta blocker. You've got a condition that promotes cardiac activation, and this is what it is. You've got to treat it and treat it well. Okay, so what's the evidence? We can't do an exhaustive treatise on the subject, but what are the potential risk factors leading to side effects that cause people's problems? Malocclusion, open bite, stress, cross bites. One thing we know is that there's a higher prevalence of TM disorders, of TM joint disorders, when you are prescribing oral airway therapy devices. So let's deal with that right now. Okay, it's well appreciated that patients we are treating for sleep-related breathing problems are likely to develop symptoms of TMD. Why is that? Well, think about it. Patients with obstructive sleep apnea generally have smaller mandibles, so their tongue rests farther down their throats, and they're more likely to develop sleep and breathing problems. It's really quite simple. Why do they develop, and if you look at the chart here, why do they develop frequently intracapsular problems as well? Well, also with small mandibles, the lower jaw, the mandible can close back into the glenoid fossa excessively, causing excessive intracapsular pressure, which will cause a disc displacement disorder or aggravate one that is pre-existing. Okay, and so you have to deal with it. It's very common, and disc displacement disorders that are stirred up or aggravated will keep muscles tight, and it's muscles that's the issue here quite often. So I'm going to be a little dogmatic here. The only TMJ splint I would recommend, it's not a flat plane. Get rid of flat planes from your armamentarium. Okay, they're permissive splints. They're not indicated for intracapsular problems. They are not indicated for intracapsular problems. Flat plane splints can aggravate both the TMJ problem and the breathing problem. So an ARS is what you want to really consider. Okay, yeah, that's a bit dogmatic, but if that's all you took away from this presentation today, I will consider this to be successful. So here we have it. Okay, continuing with evidence, here's a good resource, the Oral Facial Pain and Headache by Benaleo, edited by Benaleo, and what conclusions were drawn by this reputable author. It makes a statement that dental practitioners are accustomed to looking at occlusion to solve TMD problems. Research inescapably has concluded there's no causal relationship between the two. You can't look at malocclusion and consider that to be a significant risk factor for causing or perpetuation of adverse symptoms from repositioning the mandible. It doesn't affect, the occlusion does not affect this problem. Okay, well, your DSM patient's having symptoms, and you notice that he or she has an asymmetry. The mandible, the midlines might be off, midline disparity, might be a crossbite. Is that an issue? What would Manfredini, who's a credible source, what would he and his colleagues surmise from the evidence? The summary of opinions were that dental asymmetries are not going to initiate or perpetuate adverse symptoms in a dental sleep medicine patient significantly. And midline disparity should more likely be seen as a comorbidity from repositioning than a causative factor. Okay, continuing with this illustrative case, here's JP, diagnosed with moderate sleep apnea, age 22, unable to tolerate CPAP, so he came to us for help with this problem. So we manufactured a SomnoMed oral airway therapy device, and this is what we saw clinically with the mouthpiece in place. There was asymmetry. That's where his mandible tracked. We did an acoustic reflection evaluation. Everything said advancement with vertical. I was not concerned about the disparity in the midlines. That's just an asymmetry. So we proceeded. He was comfortable, was sleeping better, wasn't snoring. So we decided to do a post-treatment home sleep test. We gave him a watch pat, and here are the results. So here's old JP, and he didn't like that disparity with the midline. This was an intelligent man, an engineer. And he said on more than one occasion, I'm concerned that my bite is asymmetrical. He was inconsolable about that midline disparity, and adamant that it's going to cause future problems, even though he's been very comfortably wearing this appliance every night. And despite the fact that his apnea had reduced tremendously, he wanted something done about it. Here are some hand-articulated models, and the point that JP made was, look, my bite is normal. Why is it off the side? I'm concerned it's going to cause long-term problems. And we know from literature and the evidence that occlusal disparity is not a risk factor significantly for TMD adverse symptoms, but despite telling him that, he was unrelenting, actually. Okay. I wasn't too concerned, especially because the apneic events had declined appreciably with my device, so I knew I had done my job, but I had a patient with questions and concerns, and fortunately I was in grad school at the time, back in Tufts, and I brought this to the attention of Dr. Mehta, and he said, look at the frenal midline, and then look at the dental midline. The frenal midline is more coincident than the dental. You must have a structural difference, maxilla, mandible, and go with the frenal midline. And that explanation worked for me, and that's what I reported to JP, but he was not satisfied. So this is what I did. So I made him a monoblock. Okay, I mounted the models with the Coletti, got the midlines, the dental midlines aligned, and this is what I made for him. Okay, everything's lined up the way he wants it. And we provided a watch pad for him again to check airway response to this. And here's what we saw. So here we are, the comparative studies, and it was quite obvious that the dental asymmetry was not an issue, and that he was actually sleeping and breathing better with the frenal midline versus the dental midline being coincident. So I think the take-home message here is that if you see dental disparity, look at the frenal midline, use that as a guideline for the dental, and let the numbers dictate what you're going to do with that patient. And in this particular case, we made no changes. The oral device, and he was happy with that and felt much better. So if I have a symptomatic patient, I am less inclined to look at the dental occlusion as the possible cause of the symptoms. I'm going to look more at the muscles as the probable source of my patient's problems. So for the remainder of the presentation, I'm working off the hypothesis that the nemesis repositioning of the mandible for the treatment of OSA is due to the activation or formation of myofascial trigger points within the inferior belly of lateral pterygoid muscles. And that's saying a lot, but that's what I believe, and that's what I'll show you. So the lateral pterygoid muscles act in concert with other muscles, but primarily lateral pterygoid muscles advance the mandible. Okay, so when we're using repositioning devices, that mandible's coming forward and it's staying forward all night long. Why is that a problem? Again, here is the lateral pterygoid to your left without repositioning. And we put that device in there, and now that mandible's forward and that lateral pterygoid is shortened. And that sets the scene for development of a dysfunctional muscle, a formation of trigger points by virtue of it being shortened like this all night long. I'll explain this a little bit more detail in just a moment. So when your patient complains of earache, mid-face discomfort, the bite feels off, can't get the back teeth together, If you look at the pain diagram to the right, these are a classic presentation of lateral pterygoid myofascial trigger point pain and symptoms. Lateral pterygoid refer pain patterns are reproducible, and you'll often hear complaints of earache and discomfort, almost like a sinus pain. Front teeth hit first, can't close on the back teeth. And again, these are very common and reproducible signs and symptoms of a dysfunctional lateral pterygoid muscle. So, what the heck are myofascial trigger points? They are taut, palpable bands or banded areas of skeletal muscle, voluntarily controlled muscle, like muscle of mastication, arm, as well as the neck and shoulder muscles. And any skeletal muscle is voluntarily controlled and can develop trigger points if the muscles are abused. And keeping a muscle short and tight all night long abuses that muscle. There is a tender knots or nodules in those muscles. You can feel them in your shoulders. The lateral pterygoid is a little more difficult to palpate those muscles. You can provoke them though, and you'll reproduce the pain patterns that I showed you in the last slide. Again, and the pain patterns are reproducible almost every time if you compress or even stretch the muscle out. And it restricts limitation of motion. So those are the four necessary inclusional criteria to define something as a myofascial trigger point. It's tight, knotted up muscles. And it's one thing to have in your neck and shoulders, which can cause a lot of headaches. But when it's in your face, in your jaws, it's hard to shake that off. It has to be addressed. By way of introduction, for the next slide, which is a video on the subject of myofascial trigger points in pain, you'll hear that trigger points are formed by repeated injury or trauma to the muscle. In the case of the lateral pterygoid, which will be the focus for the remainder of this presentation, the trauma is the foreshortening, the cramping up of the lateral pterygoid muscle because of mandibular advancement for the treatment of obstructive sleep apnea.
Trigger points are developed as a result of muscle injury, which can be caused by acute trauma, such as sport injury, or chronic muscle overuse brought by repetitive activities, emotional stress, or poor posture. A trigger point is composed of many contraction knots where individual muscle fibers contract and cannot relax. These fibers make the muscle shorter and constitute a taut band, a group of tense muscle fibers extending from the trigger point to the muscle attachment. The sustained contraction of these fibers compresses local blood supply, resulting in energy shortage of the area. This metabolic crisis activates pain receptors, generating a regional pain pattern that follows a specific nerve passage. The pain patterns are therefore consistent and are well documented for various muscles. Treatment of myofascial pain syndrome aims to release trigger points and return the affected muscle to the original length and strength. Common treatment options include manual therapy, such as massage. Manual therapy involves application of a certain amount of pressure to release trigger points. The outcome of manual therapy strongly depends on the skill level of the therapist. The spray and stretch technique. This technique makes use of a vapor coolant to quickly cool the skin while passively stretching the target muscle. A sudden drop in skin temperature provides a pain relief effect, allowing the muscle to fully stretch and thus releasing the trigger point. Trigger point injections with saline, local anesthetics, or steroids. Dry needling. Insertion of a needle without injecting any solution is reported to be as effective as injections.
So again, for some of you, this is new stuff and very simple review. So any skeletal muscle, any voluntarily controlled muscle, skeletal muscle, can form trigger points. So if I'm on the phone all day long and I've got my my phone between my chin and my shoulder, and I'm keeping that muscle short, I'm going to develop contraction knots. Okay, those will normally stretch out if I stop doing it, but if it's repetitive, continuous, those knots may remain there. So the lateral pterygoid is the most often offended muscle when we're treating people with sleep apnea, because with that appliance in place, the sarcomere is shortened. And if it's done for hours every night, every day of the week, every night of the week, you'll have the formation and perpetuation of contraction knots. And that will lead to the formation of active trigger points. And here you see those little trigger points that are in that muscle, and they'll stay there forever until you do something about eliminating them. Okay, let's learn how to fix these problems. I'm going to talk about morning occlusal guides, and you all know about these things, and I used them for years, and that's all I use. But then when I wasn't getting the results I wanted, I started to consider the whole process, and with my understanding of muscle and myofascial pain, it occurred to me that I could do something better than just having a patient bite on these in the morning and hoping that's going to take care of the problem, which it can for a lot of patients. But I would submit to you that these stretching techniques I'm going to demonstrate generally are more effective. Okay, let's get on with it. What are some of the techniques? We'll talk about the AM aligner morning occlusal guide and the morning positioner morning occlusal guide. Then I'm going to, some of you might have heard about bite tab techniques. I'm going to show you the use of bite tabs. I think they can be extremely effective, much more so than in many instances than the MOGs. And retrusive jaw stretches, I call the Jay Leno stretch, and I know I probably have to change that out because of the youth of people coming up in dentistry. They are not going to appreciate that Jay Leno had a very protrusive jaw. Anyhow. And lastly, lateral intrusive jaw stretching techniques, which I really like. And they're extremely effective if you do them correctly. And you prep your patient for them being a little uncomfortable. And remember this, if I'm stretching muscles, it's going to hurt. And if it's a leg muscle, I can probably tolerate it more than a facial or a jaw muscle. But stretching exercises can be uncomfortable until you get that muscle, those trigger points stretch out. Okay, I'm going to go through this pretty quickly. The AM aligner, you have to get some of this material, and you order it directly from your dental rep. So here we go. We got this from Patterson, and this is what you'll receive. I don't use this much anymore, so it may be packaged differently, but what it looked like when I was ordering it. Okay, so you get your thermocryl, you heat it up in hot tap water, and you have your patient bite into it, and you tell them to close as if they're going to squeeze their back teeth together. Okay, close tight and let it cool a bit, and you take it out, and you've got your morning occlusal guide. Through trial and error, we determined that to modify the thermocryl a little bit prior to having a patient bite into it gave them a little bit of an indexing, and so you could get more retrusion of the mandible when they were using these. So I'll show you the modified technique. So you cut off maybe the last molar and a half, or at least you want maybe at least half of a molar and bicuspids forward, but you cut out those rear ends, and you tell your patient, okay, you heat it up, put it in the mouth, and close until your back teeth come together. Okay, so you've got mandible in the most retruded interdental position that you can have. Have them close into it and get your back teeth touching. Okay, and that's a better indexing, and you'll be a little more retrusive and get more lateral pterygoid stretch doing it this way with the modified thermocryl. Again, if you're indexing with more retrusion, you get more stretch, and having that modified thermocryl and telling them to bite into it so your back molars come together, it works pretty well. That was a good modification. Again, this is what it looks like intraorally, and tell your patient to bite pretty firmly until those back teeth are hitting pretty evenly. And there might be perforations through the AM aligner. Don't worry about it. This is just a repositioning jig or index, and it's not going to be in there all day long. Okay. This is what it will look like on the maxilla. We turn it down the front. And it overlaps the lower anterior teeth a little bit, and again, that gets that mandible starting to be retruded immediately upon insertion in the mouth. Okay, well, here we are to the left with the AM aligner in between the teeth versus the patient closing and central occlusion, and there'll be a little bit of lengthening of the lateral pterygoid with that AM aligner in place versus CO, but they're basically dental determined positions. So you're limited as to how much retrusion you're going to get when you're relying upon the interdigitation of the teeth, whether the AM aligner is in there or not. It's just a way to get that mandible back a little bit. It's been cramped forward all night long, but the retrusion is somewhat limited because the teeth are contacting either way. Okay? That's the deficiency in this system, in my opinion. So again, it begs the question with the morning positioner, is it really effective in lengthening the lateral pterygoid? And it's somewhat effective. Hold on, let me see. With in-situ relation versus central occlusion guided by the AM aligner, there'll be some modest lengthening of the lateral pterygoid. At least it's an index. If that mandible's been forward all night long, it's real sore. It's a way for proprioception to get that mandible to start sliding back, because you're going to be fighting the discomfort of that muscle. So it's modestly effective. It will help many times, but it won't fix the problem all the times. And that was when I was running into the more patients I treated, it was inadequate. Okay, again, the AM aligner in many instances can help. It can oftentimes fix the problem, getting that mandible back, getting those pterygoids stretched out, so the bite's restored and the patient not having discomfort. But on the occasion that it's not, is because by virtue of its design and the teeth are coming into contact with one another, you have a limit as to how much retrusion you can actually get. Hence, you're limited as to how much stretch on that lateral pterygoid you can get. You almost need a border movement sometimes, an over retrusion. And when you're using the teeth as a guideline, you're limiting how much retrusion you can introduce to stretch those muscles out. So it's self-limiting. And as this diagram suggests, that condyle needs to get back further into that retrodiscal tissue. And it might be clicking and popping more when you do it, and it might be uncomfortable. The discomfort's only coming from stretching that muscle out that has a buildup of lactic acid, it's swollen. It's like any muscle, like a hamstring muscle you stretch out. It's going to hurt. But getting that mandible back further the condyle back further to stretch out the pterygoid is what's required. And again, the AM aligner is limiting. Okay, another popular morning occlusal guide is the morning positioner, or the MP. Stating the obvious, it has a pivot, which helps to move that mandible around a little bit more, but is it really effective at addressing the problem? A shortened lateral pterygoid muscle, okay? And I would suggest that it might be problematic to get the most stretch into that muscle using this device. To stretch the lateral pterygoid, we have to drive that condyle back. It has to be pushed proximally into the retrodiscal tissue area and towards the rear wall of the fossa to get that pterygoid stretch out, because it inserts in the head of the condyle. Is the morning positioner going to help move that condyle or force it back when it doesn't want to because the muscle's tight towards the rear wall of the fossa and stretch that muscle? And certainly by having a slick surface to function on, you can move that mandible around more easily by sliding the teeth against it. But it's designed more for depression than for retrusive movement or proximal movement of the condyle, so that lateral pterygoid won't be nearly as stretched as it could be otherwise. It needs to be forcing that condyle, facilitating proximal movement of the condyle, not inferior. So I did not find that to be particularly effective. So from centric relation to a stretch position, is the lateral pterygoid being maximally stretched? Again, I would say not. It's more for inferior movement than retrusive. In lieu of the morning occlusal guards, okay, Immeliner and morning positioner, let's talk about some other techniques. I call them jaw thrust, bite tabs, and lateral intrusive stretches. Okay, bite tab exercises or stretches. You're gonna be moving your mandible proximally, stretch those pterygoids. And if you squeeze real hard, that mandible will go back. And it's almost like that bite tab pushes your jaw back more. If you're reaching for the molars to touch, you'll slide back more, and your teeth will compress that, and the elastic forces will actually push your mandible back a little bit. But it's just a way for you to keep your mandible sliding back. And if you're doing this correctly, that tab will move, will kind of move, point downwards. As you squeeze correctly, it'll point down like towards your toes. So that's how you know that you're doing it correctly. You're not just biting on it. Not at all. You're trying to get your back teeth together by squeezing as hard as you can, and that's there to protect your teeth from crashing into one another. It really works. Okay, jaw thrust, another great stretch and with minimal limitations. Show you what I mean. Okay, jaw retrusion. Don't worry about any popping or cracking. If your jaw joints, if you have a disc displacement disorder, a lot of people have asymptomatic internal derangements, it's going to make your jaw click more. Don't worry about it. I just want to get that jaw back. I'm more concerned about stretching the muscles out than exaggerating the click. So you stick your jaw forward, okay, like you stick it hard, and your head's like a golf ball. You want to, you're going to lean out. You're going to. This is the T. Your fist is the T. Lean, stand up, lean out over it. Okay, with your jaw forward. Okay, and then just let your jaw go back. Plunk. Just let your jaw go back. Allow it to slide back with your jaw going right towards your ear. Okay. Hold that for about 6 seconds. Just you're leaning out over it, letting it like gravity, the weight of your head, push your head down, which will force your jaw back. Pardon me. And that's a very aggressive and a really excellent stretch of pterygoids. You have to kind of ease into that. It'll hurt, but after a while it won't, because the muscle's getting stretched out, and the trigger points as you lengthen a muscle, you're unraveling the trigger point. And when you physically unravel it and keep it stretched out, those sarcomeres will retain their normal resting length. That's what you want. You want those sarcomeres, or the muscles, the components of the muscle, to stretch out. Okay, a little more detail on this. The technique does allow for real aggressive stretching of that pterygoid muscle, even though there are some limitations anatomically. The rear wall, the fossa of the TM joint, but because you're leaning out over your fist, you've got gravity pulling you down, the weight of your head pushing you down. It's one of the more effective techniques. I would do the other ones first before I would do this one, because this is more aggressive, but it's just another weapon to have. You may have internal arrangements, or your patient may have internal arrangements, but because there's no real dysfunction, the joints are well lubricated, so they don't notice a click. But if they notice that they feel or hear more clicking, they haven't caused any harm, they didn't tear ligaments. You can't tear ligaments doing this control stretch, but they just might notice it while they're doing the stretching. Again, the discomfort's coming from the trigger point. You're trying to stretch out. You're lengthening that muscle, and that when you lengthen the muscle, it unwinds the trigger point that keeps that sarcomere, the sarcomeres all short. As you lengthen the sarcomeres, the activity of the trigger points goes away, because you have better blood flow, and with blood flow becomes more oxygenation. Osmotic gradient changes, so myositis declines. Terrific technique. And so you want to let that mandible go straight back towards the real wall of that socket. Okay, this is a very effective, clever stretch. And again, if you understand the anatomy of the TM joint, you'll understand why this works very, very well. Now you can get a grip of your patient's mandible and just say relax, and you can kind of manipulate that jaw. And if they'll let that lateral pterygoid muscle relax, you can thrust that jaw back, and but you're limited by the glenoid fossa, the rear wall of the socket. Okay, so you can you can push it back there, and you can stretch that muscle out. But the lateral intrusive stretch allows for more stretch, because you're not only retruding the mandible, you're pushing it laterally as well. And with lateral movement, you get more stretch of the pterygoid. You'll have to review the anatomy to get full appreciation for this, but the next slides may show that. Okay, so what you're doing here is you're pushing the mandible back, but you're also pushing it laterally. It's to the ipsilateral on the same side stretch. When you push if you remember now, the pterygoid muscle originates in the pterygoid plate on the medial surface of the head and inserts in the condylar fossa. And so if you move the mandible back, you'll get some stretch. If you move it sideways, you're pushing the condyle away from the body, but that pterygoid muscle is still attached. Now you're limited somewhat by the joint capsule, but you can get a lot more stretch because of the lateral component to the stretch. Enables you to manipulate that mandible farther away from the skull, so to speak, and along with it comes that pterygoid muscle. And guess what? You stretch it out beautifully. It's a very effective stretch. It's the lateral component plus the retrusion that makes this outstanding. You have fewer anatomic restrictions. That's the whole key. So this is you're looking at the head, the mandible inferiorly, and you're seeing on the right-hand side, you can see as I move that mandible laterally, how much of a direct impact that has on the length of that pterygoid muscle. Much exceedingly more than if I'm using an AM aligner, morning positioner, a lot more than if I'm doing a chin thrust or a bite taps. Although those are in most circumstances, those work very effectively. But for a refractory pterygoid muscle that's not stretching out well, this will really help get it done. Okay, you just have to be aggressive, and you've got to do it enough. I tell my patients 6 reps, 6 times, 6 reps for 6 seconds, 5 or 6 times a day, or throughout the day until you're getting that muscle stretched out more easily, and your bites staying normalized more and more. Again, it's with that pushing laterally and retrusively as the condyles move, you're getting more stretch, and it's because you're not limited by the boundaries of the gonite fossa. This is really like a border movement. It's beyond what the jaw joint normally will permit, but because you know the anatomy, you know the origin and insertions of the muscles, you can exploit that with your knowledge and get a much better stretch. And again, being redundant, no pain, no gain. It's going to hurt, but tell your patient to ease into it, and pretty soon that pain will subside and that bite will be forever restored, and you'll be so glad you took the time to show your patient these techniques. And I draw an analogy when I'm explaining this to my patients. I say, stretching this muscle out is no different if you're at the gym and you're working out, your muscles are all tight, and I've got to touch those toes and it's killing me. I'm not going to back off or start crying because I'm worried about causing damage to my knees or whatever. I'm not going to tear my muscles just by trying to get my hands down there to touch my toes to stretch out the quads. I'm going to slowly ease into it and put up with the discomfort because I know the greater good's coming. Okay? Okay, here's a video demonstrating bite tap stretches, lateral retrusive, and chin tuck stretches. Enjoy. Next, I'm going to show you the bite tap stretching exercise. And I keep these in my pockets all day long, and I go through a lot of them. The bite tap material is made from mouthguard material. The sheets are 3 millimeters thick and 125 millimeters square, assorted colors, 10 per packet. And we cut them approximately in 1 centimeter width and 2 centimeter lengths. You can get a whole bunch out of one sheet. But I think it's important that you demonstrate this clearly to your patient because it can be done very right and very wrong. It's simple, very effective, but it has to be demonstrated. Okay, Kathy, here's a bite tap. I'm going to place it on the left-hand side of your mouth between your back teeth, so get a good grip. Okay, I'm going to have you squeeze a little bit on those back teeth with that bite tap in between. Squeeze and release, and squeeze and release. And you're going to do that about 6 times, about a 6-second squeeze for about 6 times. We call it the 6x6 exercise. And if your jaws are really cramped up, we'll have you do it 6 times a day. So 6x6x6. And always think one thing. I'm trying to get my back teeth together when I'm squeezing on this bite tab. You won't be able to because of the thickness of the bite tab, but you're trying to get your jaw back and your back teeth together. Okay, that's great. Let's move to the other side. Kathy, we're going to do the same thing on the right side that we did on the left. Here's the bite tab. Just try to keep squeezing as if you're trying to get your back teeth together. And again, squeeze and release, squeeze and release, trying to get your back teeth together. It may be really uncomfortable, and that's an important point. This may really hurt at first, and that only means you're going a little too quickly. This next stretch is called the lateral intrusive jaw stretch exercise. It's a little more complicated, but very effective. Review the anatomy of the areas. You'll understand why it's not going to cause harm. The patient may hear some noises and be a little concerned, but you might find, as I have, that of all the stretches, this can give the most results the quickest. Here is a graphic representation of the stretch I'm going to teach you now, the lateral intrusive jaw stretch. Tell your patient if they hear popping or cracking or clicking not to worry, because you'll be moving the jaw away from the jaw joint and you're not going to be causing harm. If you review the anatomy of the TM joints and the muscles, it'll reveal why this is so effective a stretch, because we're not only protruding the condyles maximally as we did with the bite tabs, but we're adding a lateral component as well. So the condyles are actually moving away and back from the cranium, if you will, in the opposite direction of the origin of the lateral pterygoid muscle from the pterygoid plate into its insertion, which is the pterygoid fovea of the mandibular condyle. So you're getting maximum elongation of that muscle with a lateral and retrusive movement of the jaw. Okay, Kathy, put your left hand on your left temple and then your right hand on your chin and slowly push that jaw as far as it can go to the side in a very controlled manner. It'll rotate as it should naturally. And keep on stretching that muscle till it starts to release. And you hold that stretch for about 6 seconds. Then relax and take a deep breath. And as you exhale, push again and hold it for 6 seconds. And we're going to repeat this process to both sides. Okay, Kathy, then repeat the same process. This time we'll be stretching the right lateral pterygoid. So you place the right hand against your temple, and with your left hand, you'll push on your chin to the right as far as you can move it. Try to get all the slack out of that muscle. And you'll hold that for 6 seconds, and you'll repeat that 6 times. This next stretch I refer to as a chin tuck exercise. It's a very simple exercise. It's extremely effective, and it puts a lot of pressure on the jaw joints directly. So one bit of caution, if the patient has acute TMJ disorders where the discs are displaced, or they have a retrodiscitis or capsulitis, a lot of jaw inflammation, a recent history of jaw joint locking, I would avoid this stretch, at least initially. So Kathy, make a J Leno. That means stick that chin out, all right, and lead with your chin. Place your chin on your fist and let that jaw retrude back. I like to tell people, think of it clunking back. I want to reiterate an important point, that you're trying to get your patients to think clunk, let that jaw clunk back so you're getting the maximum stretch. Otherwise, again, they try to open their jaws to accomplish the stretch. However, if a patient's had an acute TMJ problem, a history of locking, and maybe they haven't dealt with their TMJ problem yet, certainly the mandibular advancement device, worn for sleep apnea, is going to give that TM joint some support. But I would go a little bit easy with this stretch if they've had an acute TMJ flare or locking recently. This is a very aggressive stretch, but it's very successful, and it forces that mandible back to its absolute rearmost position within the glenoid fossa. It is truly a maximum border movement and retrusion. Thank you for attending. I hope this has been helpful and practical for you in treating people with oral airway therapy devices. And there are some documents I'm absolutely willing to share with you, including the video you just saw. So if you send me an email requesting the documents presented here today, I'll be happy to accommodate you. And thanks a lot on behalf of the Wisconsin Sleep Society.